When assessing an ill or injured child, the goal is to quickly recognize conditions that may be life-threatening or may become life-threatening if not cared for right away. If a child is not breathing or does not have a pulse, rescue breathing or CPR should be started right away. And if a child has a pulse and is breathing, then critical signs to look for are respiratory distress, respiratory failure, and shock. These are the most common issues in a pediatric patient that can quickly lead to respiratory or cardiac arrest. Now, the main idea is to constantly evaluate, identify, and intervene until the child patient is stable. For example, a primary assessment is done to evaluate immediate life-threatening conditions. If an immediate life-threatening condition is identified, we would intervene with the proper treatment. If the primary assessment does not show immediate life-threatening conditions, a secondary assessment should be done with a focused medical history and a focused physical exam to evaluate conditions that may need to be addressed. After this, other evaluation tools may be needed to diagnose a child's condition, such as labs, radiographic, and other advanced tests. Now, to begin evaluating an ill or injured child, one should use a systematic approach in order to unify and stay consistent with that assessment process. First, form an initial impression. This is a quick observation formed in the first few seconds of the child's interview and assessment. Appearance, breathing, and signs of circulation are all evaluated at this time. This will help us determine an initial need for care of life-threatening conditions and the urgency for treatment and transport. Perform a primary assessment. If when tapping and shouting to the patient we find that the child's unresponsive, we'd call for help or activate the emergency response system. Next, we would check for a pulse and signs of breathing. And if there isn't any breathing, but the child has a pulse, we would provide rescue breathing at 1 breath every 3 seconds. And if there is no pulse, we would begin full CPR. Remember, if a child's heart rate is below 60 beats per minute with signs of poor perfusion, we begin chest compressions. Now, if there's no life-threatening emergency, we would continue forming our initial impression of the child by looking at 3 primary signs: the overall appearance of the child, their effort for breathing, and their circulatory status. It's important to try to keep the child as calm as possible. Let the child stay with a parent or a caregiver, if it's practical to do so, while we perform those initial assessments. Now, we may need to use a toy to distract the child in order to keep them calm while performing the assessments, but be creative. Try to find a way to put them at ease while we're doing this evaluation process. It's all part of our professional know-how. Then, to evaluate the overall appearance of the child, check the child's level of consciousness and ability to interact. Now, one key note here, make sure we're looking for things that maybe only a caregiver would know. In other words, I could say, is this the normal level of reaction that this child does for you under the certain circumstance? And follow what the caregiver says to get a baseline understanding of what is normal for this child. We know that they're all over the board. Some are very calm, some are very excitable, some cry, some don't cry. So look for abnormal normalities. And when looking at the child's eyes, is there a normal look, or do you see a gaze or an unusual stare, almost like they're looking through you, or they're not really in the program? Does the child appear to be in pain? Is the child acting normal? What is the child's muscle tone? Is the body position normal for this child? Is the child's verbal response or cry normal? For the next part of the initial impression, we're going to look at the child's breathing. We want to determine whether a child has increased respiratory effort by assessing the patient's position, the amount of accessory muscle use, and sounds of breathing that can be heard without a stethoscope. Is the child in a tripoding position? This is when the child leans forward with the hands on the knees, trying to keep the pressure off the lungs and the diaphragm in order to breathe deeply or adequately. Do we see retractions or nasal flaring or accessory muscle use? Do we hear stridor? Unusually deep or shallow respirations, wheezing or grunting or crackles. Remember that if we see these signs of respiratory distress, don't delay treatment of that particular condition. This is an emergency, and respiratory distress can quickly lead to respiratory arrest in a child. Now, the last part of the initial impression is to evaluate the child's overall circulatory status based on general color. Any severe bleeding would need to be controlled, and we should ask ourselves questions like the following. Does the child have pale, mottled, or cyanotic looking skin? Now, if the child has a dark skin complexion, look on the inside of the lips for the mucous membrane or to the fingertips or nail beds. These can help us when we have different pigmented discolorations or colorations, when we can't tell whether the person is cyanotic or if they are pink, warm, and dry. Cyanosis of the lips and the fingernails are early signs and symptoms of a circulatory compromise or oxygenation compromise. And these symptoms can be a sign that the child has inadequate oxygen in the blood. A flushed appearance can suggest fever or shock. Bruising on the skin can suggest injury or internal bleeding. And the idea is to quickly assess how well the child is perfusing through this simple observation. So in review, a systematic approach includes forming an initial impression. We do this by visualizing the child's overall appearance, the work and effort for breathing, and the signs of the circulation by the appearance of the skin color, and using a primary assessment to determine life-threatening conditions with the ABCDE approach. As part of the primary assessment, establish baseline vital signs by measuring respirations, their blood pressure, and a pulse oximetry. After the primary assessment is performed, a secondary assessment to determine other conditions which may need treatment should then proceed. We want to continue to reevaluate, identify, and intervene as treatments are given or the child's condition changes.